Hello, everyone. Welcome to our July ICARE case conference. I'm Tua Pal. I wanted to start off with a case aligned with our guest expert speaker's presentation today. So this is not my case. It was a case that Dr. Ronnie Alvarez sent to me that he had. And this is a patient currently 66 years old. In 2017, she had advanced stage recurrent or advanced stage ovarian cancer age 58, which has recently recurred. Um, she was treated with THBSO, hemicolectomy. She had a mixture of Taxol, carboplatin, then docetaxel, and carboplatin. Genetic testing identified a RAD51C mutation, and here is the specific mutation. 2018, she had a recurrence, completed again, another cycle, doxil carbo. 2018 to 2022 was put on olaparib maintenance when she was then diagnosed with MDS, treated with decitabine and venetoclax until late 2023. Additional MDS treatment started in January 2025. And again, what you can see is she's actually doing pretty well. She's got some other risk factors like long-term smoker, has COPD. She's, again, excited about many things in her life. You can see the family history where mom had breast cancer age 75, and then maternal grandmother with melanoma, maternal great aunt with stomach cancer. So with that, I wanted to introduce our guest speaker today, Dr. Elizabeth Swisher, who's the Deputy Director at the Fred Hutchinson Cancer Center, University of Washington. She's professor in the Division of Gynecologic Oncology at the University of Washington. And again, she probably doesn't need much of an introduction, but she's had longstanding interest in genetics, personalized therapy for gynecologic cancers. And her focus today will be myelodysplastic syndrome and acute myeloid leukemia following PARP inhibitor therapy. So Dr. Swisher, just wanted to get your perspectives on the case that we just presented, or that I just presented, and then we'd love to learn more from you today.
Yeah, thank you, Tia. I'm really happy to be here today. And thank you for finding a case I'm going to start off my presentation with a case, and I think you'll see some parallels there. So one of the reasons ovarian cancer patients have such a high risk of therapy-related myeloid cancers is that we treat all of our patients with platinum-based chemotherapy, which is one of the more leukemogenic chemotherapies. So there's a baseline risk, and then PARP inhibitors add to that risk. And so the person who has the highest risk are people who have had more than one regimen. So this patient that you presented had two different regimens that were platinum based, and then an extended period of PARP inhibitor maintenance. So the maintenance trials, now we've moved PARP inhibitors to the upfront setting, I think, where we see a lower risk of AML and MDS, but these patients who are treated in the recurrent setting, by definition, have had at least two different full treatments with platinum. And then those trials, there wasn't a limit to when the PARP inhibitor was ended. So you treated until progression. So we have patients treated in this era of this patient who got, as this patient did, 4 years of PARP inhibitor. And in the upfront setting, patients are getting 2 years and just one regimen of platinum. And now there's a clinical trial ongoing at the NCI through NRG oncology group, where we're comparing 1 versus 2 years, because even that 2 years, it was just arbitrary. As some of you may know, in breast cancer, the maintenance approval for olaparib with patients with germline BRCA mutations for breast cancer is 1 year. That also was arbitrary, so nobody's really compared that. So understanding that risk benefit ratio, we've massively improved outcomes for patients with ovarian cancer, but AML, MDS is like a potentially fatal diagnosis. And many of these patients, the PARP inhibitor related ones are usually P53 mutated. So I don't know too if you have any information, but those are the higher risk MDS for transition over time to AML, which ends up being kind of the fatal thing. So I don't know if you know her profile.
I don't because she was Ronnie's patient,
Yeah.
but that is good to know. Okay, Liz, take it away. Take away your presentation.
Okay. That was a good introduction. And so I am going to talk about MDS and AML following PARP inhibitor therapy, which kind of collectively really, there's sort of a continuum from MDS to AML and even, things that are sort of in between. So collectively, we call them therapy-related myeloid neoplasias or TMN. So I may refer to it as TMN, which is shorter. And so I was just going to present this case. This is actually a sporadic case, so I don't have a pedigree. This is a 56-year-old patient who was diagnosed in 2007, who her family history was really only notable for a father with prostate cancer. She underwent a THBSO, and it was an incidental finding of stage 2C high-grade serous ovarian cancer. She got 6 cycles of carbotaxol, which is kind of our standard regimen. And didn't recur for quite a long time. In 2018, recurred in the liver. She had a surgical resection again and got 6 more cycles of carboplatin and Taxol, and then underwent genetic testing, which was negative for germline mutation, but Foundation 1 testing of the tumor revealed a somatic mutation in BRCA2 that was pathogenic. And so she went on olaparib maintenance for 4 years, which is kind of almost the identical story to the one that was just presented, except that her mutation is somatic and not germline, which has equal predictive value for PARP inhibitors. And so again, because it was the recurrent setting, she was kind of left on it indefinitely. But this was at our institution where I was sort of like talking about AML, MDS risk, and her provider reached out and said, should she still be on it? This patient had a 11-year remission without PARP inhibitor. Now she's in remission again. And what's the risk benefit ratio of continuing indefinitely versus seeing how she does? And so after 4 years of treatment, they did stop in March of 2024, that PARP inhibitor. And she remained in remission. And they decided to stop it secondary to the risk of AML, MDS, which accumulates. And but unfortunately, 8 months later, she was diagnosed with a therapy-related AML. She was treated, initially responded a little bit, but ultimately declined and died in June of just this year. So her AML did have a pathogenic P53 mutation, which is which is classic for the therapy-related AML or TMNs. And the VAF in her blood was 42%, which was, consistent with a high blast fraction in her blood. So that I'm going to kind of set the stage there. That's similar presentation, and I'm going to kind of come back to kind of what we know about risk and how to monitor that potentially, or should we monitor that? And we have a prospective study that potentially you may run across patients who we'd be very interested in enrolling. So, oh, sorry, there's a delay. So this was a paper published off SEER Medicare data, just looking at the risk of TMN across solid tumor patients, a very large number of patients. In the ovarian, fallopian tube, peritoneal cancer group had the highest increased risk compared to other solid tumors, along with a few others, small cell lung, sarcoma, and brain. And the risk is known to be higher with certain types of chemo, platinum being one of them, alkylating agents, and radiation also increases risk as well. But PARP inhibitors further increase that risk. So this is a meta-analysis of many PARP inhibitor trials A lot of those trials were ovarian, so like 43% of the trials here were ovarian cancer patients, but that included the larger trials and the longer follow-up, so that the ovarian cancer patients contributed a lot to the TMN risk in this group. And they calculated an odds ratio of 2.6, with an incidence across the trials that was only 0.8%, but many of these trials were shorter trials, et cetera. So I think that that's actually a minimum incidence risk, and I'll talk a little bit about things that increase that risk. So these two patients represent the highest risk group for subsequent TMN, which is having had more than one regimen of platinum and then being on a PARP inhibitor for 24 months or greater. And in 2 trials in ovarian cancer, that risk is about 10%. Which is a very high risk for somebody who has a relatively good outcome in terms of their total expected life expectancy and in risk of recurrence from their secondary cancer. So in one of these trials, it was 11.4% and another 8%. But notably in the SOLO2 trial, which the PARP inhibitor treated patients that also met that the patients who got placebo instead of PARP inhibitor that met the same criteria had a risk of 4%. So just that baseline platinum exposure is increasing your risk quite a bit. It's definitely not all the PARP inhibitor. So how can we potentially predict who's at risk? So we know that somatic mutations are acquired by all cells throughout life. And CHIP, or clonal hematopoiesis of indeterminate potential, I'm just going to call it clonal hematopoiesis throughout this, or CH throughout this talk, it's a non-malignant expansion of myeloid cells where a mutation a rare mutation has occurred in hematopoietic stem cell, and it's led to clonal expansion. This is actually kind of a normal process that occurs with aging, but if additional mutations are acquired, blood cancers may result. And it is known that, sorry, I'm going to go back. It is known that P53 mutated clonal hematopoiesis is a risk factor for subsequent AML in the non-cancer population. And you can find a clone in the blood, usually number of years, like at least 5 years before the diagnosis of AML. So that sort of led us to the conclusion we were finding some of these clonal hematopoiesis in our patients on trial, and we were wondering if these are the patients that ultimately are at higher risk of, of subsequent TMN. So what we did was we took 2 existing large trials that used rucaparib from Clovis Oncology, which is now a defunct group, but they ran a couple trials in the recurrent setting. Ariel 2 was a single-arm study, so no placebo control, but looking at rucaparib as a monotherapy treatment. And Ariel 3 was in the maintenance phase, post a second or third line platinum response. So TMN across these 2 trials occurred in 2.1% of patients, and that's within a couple of years of the trial. So ultimately, that number only goes up with longer-term follow-up. And what we found, if we looked at the patients who got TMN and the patients who didn't get TMN across the 2 trials, and then did multivariable analysis for the significant factors, what came across is it's the total prior time to receiving platinum. So that's the number of months of platinum exposure is a major risk factor, and then also the total time of PARP inhibitor exposure. It is a risk factor. So one of the things is people have wondered if having a BRCA mutation itself increases the likelihood of acquiring TMN. Is there less capacity maybe to repair DNA damage in the hematopoietic stem cells themselves? And what we found in this study was, in univariate analysis, BRCA mutations were a risk factor, but somatic equally to germline. So why would that be? Because the somatic ovarian cancer mutation shouldn't be in the blood cells. But it turns out when we corrected for the amount of platinum exposure, that risk factor went away. So patients with BRCA mutations, their cancers are more sensitive to platinum. They tend to get retreated with platinum again. And that may be the fact that is leading to their TMN as opposed to the underlying genetic, predisposition. This is a retrospective study looking at who got TMN and didn't. And so we definitely want to kind of further look at that in a prospective fashion as well. So what we did was in these two trials, we took the cases that got TMN. So even though it's a large number, we just have 20 cases. And we took like double the number of cases, matched them for age and other risk factors who did not get TMN, and looked at and then did deep sequencing of their baseline blood samples and compared the clonal hematopoiesis in the cases versus the controls, meaning the patients who didn't get TMN. And looked at like what genes were involved, and it was definitely P53 clonal hematopoiesis that raised the risk factor for MDS and AML. This was using a cutoff of 1% of a variant allele fraction for the clonal hematopoiesis. So it was the TP53 mutated clonal hematopoiesis was associated with prior platinum exposure, like the amount. DNMT3A, which is associated with age, that's a common, and it did not associate with the risk of TMN. So then we had some serial samples. We used cell-free DNA here as opposed to just the blood, but most of cell-free DNA is coming from the blood, even though we're using it often to look at circulating tumor DNA. The circulating tumor DNA fraction is low, so you can use cell-free DNA also to look at the blood component of your clonal expansion. These are all patients that got TMN, and when we had samples over time, their P53 mutations in the blood were expanding. The clone was expanding over time, and these are just, 4 different examples. So we don't have patients that didn't get TMN that we had serial samples on that had a P53. So we don't know what the clonal, we just don't know what those clonal dynamics are normally during treatment versus in a patient who's gonna ultimately be diagnosed with TMN. So that led to us wanting to do a prospective study to try to answer that question. So we kind of came up with this model, which is that a patient with ovarian cancer maybe has an age-related P53 mutated clone in their blood, and they're maybe in remission, and there's stability of this clone, and then they recur, they get more platinum, which expands this clone, and then they get PARP inhibitor, which further leads to transformation of the clone to a TMN. So that was kind of like the model that we were sort of wondering if that's the case, could we come up with like a risk calculator for people to know what their absolute risk of TMN is, and potentially lead to interventions in the future. So we want to know what's the absolute risk of TMN. If somebody has a P53 clone, is that a relative contraindication, or is that somebody that should be monitored? If so, how would you monitor them? Without knowing what the clonal dynamics are in the baseline, we can't really advise about any of that. So that led to this study that's an R01 funded study. We call this study CHANCES, which stands for Clonal Hematopoiesis in Cancer Survivors. And our goal is to better understand that relationship between cancer treatment and the development of secondary blood cancers, or TMNs, and to develop a risk calculator for individuals so that we can identify who's at higher risk and ultimately prevent the development of TMN in cancer survivors. So our study eligibility is patients who have had, ovarian, peritoneal, or fallopian tube cancer, who plan to complete, so we could enroll them at baseline at least 5 cycles of platinum-based chemotherapy. They can be in remission. They can be in remission. They can be in recurrence. They can be at any point in their ovarian cancer journey, except we want at least 6 months of expected life expectancy because we're trying to follow people over time. And then we are also wanting to recruit patients with other solid tumors who have PARP inhibitor exposure. So we didn't want so much heterogeneity of just taking all cancer patients. but we do want more diversity of cancers that are being treated with PARP inhibitors. So anybody who's going on a PARP inhibitor or has been on a PARP inhibitor for 4 months or more, we would love to enroll that individual. And across the spectrum of age is like useful for us. So we have enrolled. So this is kind of how it goes. If somebody wants to enroll, they enroll entirely online. They fill out a REDCap form with their treatment history. They provide us a blood sample with a kit that we ship to them. And we get a blood sample every 6 months for 3 years. And each 6 months, they give us an update, a short survey on their treatment exposures so that we can sort of look at how the clones are behaving in people who are not on treatment versus on treatments and treatments of different types. We freeze the blood viably, and then we sequence on a custom panel that we call BROCA-MY for myeloid that can identify clonal hematopoiesis with confidence to less than 1%. We only consider like clonal hematopoiesis for pathogenic or favor pathogenic variants in the genes on our panel. So I'm just going to wrap up with like a last case. So this is an unfortunate case that I took care of this patient. She happened to have a history of Hodgkin's lymphoma in 1993, where she was treated with like high dose chemotherapy, chest radiation, and stem cell transplant. So quite a lot of exposure prior. And so this is really relevant to our patients who have more than one cancer. What is their prior exposure before they're even getting treated for their current cancer? And in 2016, she was diagnosed with ovarian cancer. She had no germline mutations. And she then you can see up here at the top is kind of her treatment regimen. She had 3 different regimens with platinum, and she never did get a PARP inhibitor, but she got diagnosed with MDS, which shortly prior to her death had converted to AML, and it was a P53 related clone, and it is this K132R pathogenic variant. And you can see we actually at the time of her diagnosis, she enrolled in our biorepository. So we did have a baseline sample before she enrolled in Chances here where we got the serial samples. So we went back and looked, and she did have a low frequency, like 1% frequency of the clone that ultimately became her MDS 6 years later. And it fell here before her clone because she initially responded to MDS treatment, and the size of the clone will like you would imagine, if she's responding to treatment, that size of the clone will fall. But we didn't get a sample at the time of her death, but it had spiked way up at the time of her death. But interestingly, she has this pretty high level frequency DNMT3A clone up at the top, where she had a 13% clone at baseline. Now, DNMT3A is like probably one of the most common clonal hematopoietic genes. It's associated with aging. And, it went up a little bit and didn't really go up, the same way that the P53 did. I mean, is this a risk factor, somebody who has a large clone at baseline, even in a different gene, or is this just like an incidental kind of finding? I mean, these are the questions that we kind of hope to answer. So I'm just going to say that this study, people can enroll online. We have flyers with QR codes that if you wanted to use them. We also have business cards that we'd be more than happy to send you. This is an enlarged version of the business card, what's on the front and the back. And so it's just a business card size, and it has people can use the QR code or go to the website to enroll. They can also reach out to our email at and we would really love to enrich for patients who sometimes, you guys are doing genetic testing and you may get back a result where there is clonal hematopoiesis in a sample. A lot of the germline testing companies filter out the clonal hematopoiesis like sort of arbitrarily. Sometimes, though, you're questioning whether somebody has constitutional mosaicism or clonal hematopoiesis. Anybody with clonal hematopoiesis and cancer, we would love to enroll them because we'd love to follow what happens to that clone over time, whether or not they're on or off treatment. Then, patients on PARP inhibitors, patients who come to you, maybe they're disappointed that they have negative testing. They have ovarian cancer, and patients want to answer for why they have cancer, and you're having to give them their negative test results, and they seem disappointed. And you can say, but you could enroll in this other study if because sometimes patients want like something positive to enroll in. So I would be really grateful for any referrals, and because I think this is like a critical thing that hasn't been studied too much, I think, because of the separation of the solid tumor and the liquid tumor world, essentially. So I just do want to acknowledge a lot of all these studies, the big clinical trials involve a lot of people, but my long-term mentor is Mary Clark King, and I wouldn't really be in this genetics world without having had the opportunity, the good fortune to learn from her and work with her. And that's it. I'm very happy to take any questions.